Welcome or welcome back, depending on whether you have watched any previous video of my channel. Today we talk about the humerus bone, which is concerned with the upper limb osteology. So, as far as the humerus is concerned, let's first talk about the bony features of humerus, then we will move on to the attachments of the humerus, and then any clinical application related to humerus. So that's the order in which we will tackle with this bone. As far as the bony features of humerus is concerned, obviously, first of all, we have to describe the humerus. As we can see, humerus is a long bone because it is involved in weight transmission or force transmission in the upper limb. As far as the bony features are concerned, we can see that it has three parts: the upper part, the middle shaft part, and a lower part. The upper part, that consists of this rounded head, as we can see, somewhat spherical, with a constricted neck, and then we have the middle shaft of the humerus, and then we have the lower part. All right. So let's first talk about the upper end of the humerus. Okay, as we can see, this is the somewhat globular head. It is obviously articular because it articulates with the glenoid cavity of the scapula. Now here's an interesting thing about this fact. See, glenoid cavity is not as deep to accommodate the entirety of the head of the humerus. As a result of that, the shoulder joint is not a very strong joint. However, there are a lot of features which stabilize the shoulder joint, which we'll talk about later. On the other hand, this apparent weakness gives shoulder joint a more mobility, I would say, right? So anyways, since the shoulder joint is being formed over here across the head region, so what we can say is that the fibrous capsule or the capsular ligament for the shoulder joint, that is attached along the head region or adjacent to the head region in the neck region. All right, so let's now talk about the neck of the humerus. See, this is the globular head. Absolutely adjacent to the head of the humerus, we have a constricted anatomical neck of the humerus. This line that you see, which has been marked over here, this is the anatomical neck, which is completely immediately adjacent to the head. All right, this serves as the line of attachment along of the fibrous capsule of the shoulder joint, right? However, there are two other necks of humerus as well. The next neck of humerus, that's a little weird. The next neck of humerus, that is the morphological neck, which is this second line. What is the morphological neck? Morphological neck actually represents the line of fusion of the epiphysis with the diaphysis of the young humerus. So it has all to do with, or it has everything to do with the ossification of humerus. All right, it is the line of attachment, or it is the line of fusion of the epiphysis with the young diaphysis of the young humerus. Then about 0.5 centimeters below the morphological neck comes the last so-called neck of humerus, which is the surgical neck. Surgical, so obviously it has some clinical relevance. Surgical neck is actually forming the junction between the upper part with the actual shaft. So beyond the surgical neck, the actual shaft of humerus starts. Along the surgical neck, why it's called the surgical neck? Along the surgical neck, we see that there is a winding of a nerve, which is the axillary nerve. Along with the axillary nerve, there is an artery, which is the posterior circumflex humeral artery. They wind around the posterior surface of the humerus along the surgical neck, and hence any fracture along the surgical neck of the humerus will result in injury to those structures, resulting in subsequent, we might say, manifestations. All right. The upper part also, apart from the head and necks, they have two more important structures. As you can see, this elevated ridge or elevated tubercle over here, rather, not a ridge, this is called the lesser tubercle of the humerus. Whereas this elevated larger tubercle spanning laterally and posteriorly This is the greater tubercle of the humerus. Lesser tubercle is anterior, greater tubercle is more lateral and posterior. All of them have very important attachments. What are they? Lesser tubercle itself, which is an elevation anteriorly, serves as the point of insertion of the subscapularis tendon, whereas greater tubercle presents from the superior aspect to the more posterior and inferior aspects. It presents three flat muscular impressions. The first muscular impression provides attachment to the supraspinatus. Next one provides attachment to infraspinatus. The last one provides attachment to the teres minor muscle. So all these four muscles, that is the subscapularis in the lesser tubercle, the supraspinatus, infraspinatus, and teres minor, these four muscles, they are actually enveloping the upper end of the humerus, the upper part of the shoulder joint, forming a cuff around the shoulder joint, which is known as the musculotendinous cuff or the rotator cuff, which is an extremely important as far as the stability of the shoulder joint is concerned. Now, in between the two tubercles, that is the lesser and the greater tubercle, we are seeing a groove. This groove is called the bicipital groove, or it is also called the intertubercular sulcus. In between the lesser and greater tubercle, what we see is the upper part of the intertubercular sulcus, which is actually progressing downwards like this. As you can see, it is progressing downwards. So this tubercle, this is actually bridged by the transverse humeral ligament like this. So what this tubercle, or what this intertubercular sulcus, this actually has is a floor, and it has two lips, that is the medial lip and the lateral lip. All right, in between that there is a floor. This is actually bridged by the transverse humeral ligament, right? What are the structures that pass through this intertubercular sulcus? The long head of biceps brachi's tendon, along with its synovial sheath, passes through this sulcus. Again, the tendon of the long head of biceps brachii, along with its corresponding synovial sheath, passes through this intertubercular sulcus. It comes like this and then moves like this downwards. All right. Along with that, there is another structure which passes. That is, we had the posterior circumflex humeral artery. We also have the anterior circumflex humeral artery. From the anterior circumflex humeral artery, suppose this is the anterior circumflex humeral artery, there ascends an ascending branch which will move above through the intertubercular sulcus. So these are the two contents of the, I would say, intertubercular sulcus. All right. What about the attachments of the lips and the floor of the intertubercular sulcus? We know that the lesser tubercle itself provides attachment to the subscapularis tendon. But the lateral part of the lesser tubercle, which is the medial lip of the intertubercular sulcus, or medial lip of the upper part of the intertubercular sulcus, that is actually providing insertion to the teres major muscle. This was teres minor, this is teres major. On the other hand, the lateral lip of the intertubercular sulcus, that is actually providing insertion to the pectoralis major muscle, whereas intervening floor of the intertubercular sulcus is giving attachment to the latissimus dorsi muscle. So that's why we have a mnemonic for the three muscles of the bicipital or bicipital groove or the intertubercular sulcus. We have a mnemonic, that is lady in between two major. What is a lady? Lady means latissimus dorsi. And what are the majors? Teres major, pectoralis major. All right. Along with that, I already said, long head of biceps tendon along with the synovial sheath, and anterior branch of the ascending circumflex humeral artery. Done. The other very important aspect is the attachment of the capsular ligament around the anatomical neck. Capsular ligament, obviously, the capsular ligament belongs to the shoulder joint. The ligament's attachment is pretty simple. That is, it is along the anatomical neck of the humerus. However, there are two exceptions to this. That is, there are two places on the neck where the capsule is either deficient or extends beyond the anatomical neck. What are those two positions? The first position is corresponding to the upper part of the bicipital groove over here. What's happening there? There, the capsule is not present over this part. Capsule is not present. Capsule is deficient. Why? So that the long head of biceps brachii tendon can pass from over here up into the bicipital groove. That's why the capsule is deficient over here. That's the first exception. Second exception is over here in the medial lower part. Here, instead of continuing along the anatomical neck, the capsule is actually dipping down onto the shaft up to the surgical neck level and accommodating more of the shaft of the humerus than it was intended to. And then again it is returning back upwards. So here it is excessive, here it is deficient. These are the two exceptions to the fibrous capsule attachment. So this is more or less the entire upper part of the or upper end of the humerus accommodated for. Now let's talk about the shaft. The shaft of humerus, it has three borders and three surfaces. What are they? Obviously. Now the trick here is to always start from the inferior most part of the humerus. You need to start from the lower part and then ascend upwards. In this way, there is no confusion, right? Because in the inferior part, the borders are very prominent. As we can see, the inferior part is somewhat triangular, whereas as we go above, it becomes more cylindrical, right? So the borders of the humerus, they are the anterior border over here. This is the anterior border. The medial border, as you can see, and the lateral border. Always start from the inferior side, the lateral border. Okay, here it's a deficient, then again like this. Let's describe them now. So anterior border, see, anterior border, as the name suggests, is present anteriorly. From where is it starting? Where is it ending? How will you describe its course? This is what we will study now. Anterior border is actually starting from, we can say, the lateral lip of the intertubercular sulcus. Alright, the lateral lip of the intertubercular sulcus. So it is extending downwards, downwards, downwards. Then in the somewhat middle part, we have a groove-like area. As you can see, this is a rough groove-like area. This is known as the deltoid groove. As the name suggests, the deltoid will get inserted here. We'll see to that in a bit. So why I'm talking about the deltoid groove right now is because this anterior border, this will come down and this will form the anterior limiting part of the deltoid groove. That's the secret, right? Then it will proceed downwards, downwards, downwards. As you can see, it's shiny. The light is shining, so it's pretty highlighted over here. It's proceeding downwards and it ends in between these two fossa in the lower parts. This is the radial fossa laterally and this is the coronoid fossa medially. In between them, the anterior border will end, right? Now, we have described the course of the anterior border entirely, right? Now, let's talk about the medial border. Medial and lateral borders, for the medial and lateral borders, we have to start inferiorly. The medial border, that is actually starting from this elevated or this projecting medial bony appendage. This is known as the medial epicondyle. It starts from here, the medial epicondyle, proceeds above, and in this lower part, it is forming a sharp ridge. This is known as the medial supracondylar ridge. All right, medial supracondylar ridge. Then it proceeds above. Here in the middle part, it's presenting a rough patch, a rough strip. All right, this actually serves as the insertion for coracobrachialis. We'll see to that in a bit. So again, it presents this rough strip, proceeds above. Then how is it ending? It's actually ending as the medial lip of the intertubercular sulcus, finally ending as the lesser tubercle. All right, medial lip of the intertubercular sulcus. This is the intertubercular sulcus, entire intertubercular sulcus. Medial lip. Finally, since medial lip is a part of the lesser tubercle, so it ends as the part of a lesser tubercle. So the entire medial border, this is like, it's starting from here. So do not think that the medial border is this. No. See, that's why it's difficult actually. Start from here, proceed above. Then here, it's actually going like this, not like this. This is not a border. This is actually a surface. See, it's a surface. It's completely rounded. This is not a border, but this is a border. That's why you have to feel the bone. So that's the medial border accounted for. Let's now talk about the lateral border. Again, we have to start inferiorly. This over here, just like the medial counterpart, this is the lateral epicondyle. So it starts from the lateral epicondyle, forms what we say to be the lateral supracondylar ridge. Again, a ridge-like, sharp ridge-like structure, lateral supracondylar ridge. Then, very interestingly, it is proceeding upwards, and here in the middle part, it vanishes. It's so ill-defined that we say that it has vanished, completely gone. It's not present in the middle part. Then, as you can see, there is a groove running over here. This is the radial groove or the spiral groove. So the posterior border, it disappears in the middle part, but then again it reappears as the posterior limiting part of the deltoid groove. So the anterior limiting part of the deltoid groove was the anterior border, but the posterior limiting part of the deltoid groove is the lateral border. Then it is projecting upwards, and finally it forms the posterior border of the greater tubercle. So this is more or less the lateral border. Here it disappeared, then again it reappears here, and then finally lateral supracondylar ridge, lateral epicondyle, finished. So this is more or less about the borders of the humerus. Now let's talk about the surfaces. I just need to describe the surfaces. In between the medial border and the anterior border, this is the anterior border. This surface, this entire surface, this is the anteromedial surface. Just like that, in between the anterior border and the lateral border, this is the anterolateral surface. Then in between the lateral border and the medial border, this is the posterior surface, smooth posterior surface. All right. So that finishes describing the borders and surfaces. Let's now take a deeper look at the attachments of the borders and surfaces. So first of all, let's talk about the medial border. As you know, I said that it starts from the medial epicondyle, right? Forms the medial supracondylar ridge. So the medial supracondylar ridge is pretty interesting because this supracondylar ridge itself provides attachment to the medial intermuscular septum. medial intermuscular septum. As the name suggests, it is forming a septum. Septum in between what? Septum in between the flexor and extensor compartment of the arm. Alright? The flexor and the extensor compartment of the arm. The medial one, the medial counterpart, because we also have a lateral counterpart to that intermuscular septum. So medial supracondylar ridge is forming the medial intermuscular septum. But in front of the attachment of the medial intermuscular septum, in the very lower 1/3 part over here somewhere, the medial supracondylar ridge gives origin to a muscle. What is that muscle? That muscle is the humeral head of the pronator teres muscle, which is a flexor muscle of the forearm. Humeral head of the pronator teres from the lower 1/3 of the medial supracondylar ridge in front of the attachment of the medial intermuscular septum. Done. Now, as far as the medial epicondyle itself is concerned, the tip of the medial epicondyle, that will actually provide attachment to the anterior and the posterior bands of ulnar collateral ligaments. These are ligaments concerned with the elbow joint from the tip, whereas the antero-inferior part, not the tip, this is the tip, somewhat over here, antero-inferior part. This is a little too complicated. You might not remember this, like the actual site of attachment within the medial epicondyle. Again, you might not remember that. You might remember medial epicondyle gives attachment to this and this. Anyways, so from the tip it gave attachment to the ulnar collateral ligaments, anterior posterior bands, but from the anterior-inferior part it actually gives attachment, or rather it provides the common origin for the superficial flexors of the forearm, which is pretty interesting. You see, the forearm, it has again two compartments, the flexor compartment and the extensor compartment of muscles, right? Flexor compartment again has somewhat two compartments, some consider three compartments also. Anyways, two compartments, the flexor compartment. The flexor compartment has a superficial layer and a deep layer. The superficial flexor muscles all have the common origin from the medial epicondyle. Okay, so that's the attachments from the medial epicondyle and the medial supracondylar ridge. Now going above, see, in the middle part I had said that the medial border is presenting a rough strip. This provides insertion to a muscle which is the coracobrachialis. Alright, coracobrachialis. Somewhat inferior to that, or somewhat around the medial border itself, we have the nutrient foramen. In this humerus, we have the nutrient foramen over here, which has been marked. See, the nutrient foramen. The direction of the nutrient artery is towards the elbow joint. You know, there is a mnemonic for this. If you don't know this, the mnemonic goes something like this: towards the elbow I go, but from the knee I flee. So from the knee I flee, towards the elbow I go. So this means that the nutrient artery's direction in the upper limb is towards the elbow joint, right? That means if the nutrient artery's direction is towards the elbow joint, then the growing end of the humerus is its upper part, because it's always the opposite side which grows, which is the growing part of a bone, opposite to the nutrient artery direction, right? So that's more or less that about the medial border. Above, it's moving on, forming the medial lip of the intertubercular sulcus. Then upper part of the medial lip of the intertubercular sulcus is actually formed by the lesser tubercle, so it actually forms a part of the lesser tubercle, right? Now, as far as the lateral border itself is concerned, the lateral border again starts from the lateral epicondyle, presents upwards, forming the lateral supracondylar ridge. The lateral supracondylar ridge has an interesting attachment pattern. Again, just like its medial counterpart, it actually gives attachment to the medial or rather the lateral intermuscular septum. So the lateral supracondylar ridge is providing attachment to the lateral intermuscular septum. In front of the lateral intermuscular septum attachment, the lateral supracondylar ridge also gives attachment, or rather origin, to two muscles, in sharp contrast to only one muscle which was provided by the medial supracondylar ridge. Lateral one provides origin to two muscles. Medial one did only one muscle, that is the pronator teres. Lateral one, in its upper 2/3, the lateral supracondylar ridge is providing origin to the brachioradialis over here. Whereas in the lower 1/3, the lateral supracondylar ridge is providing origin to the extensor carpi radialis longus. Extensor carpi radialis longus muscle. Do not worry if you have not read upper limb as of yet. Like osteology is the first thing that we actually study in any section of anatomy. So do not worry after hearing these new muscle names, complicated muscle names. They will soon uncomplicate as you keep studying through the domains of upper limb. Anyways, so brachioradialis in the upper 2/3, extensor carpi radialis longus in the lower 1/3. And the lateral epicondyle itself, again like the medial epicondyle, from its tip it is providing origin, or it is actually providing attachment to the radial collateral ligament. Unlike the ulnar collateral ligament, which had anterior and posterior bands, radial collateral ligament is a single ligament, does not have two parts. However, anterolateral part of the lateral epicondyle will again provide origin, or rather it will provide attachment to the common origin for the superficial extensor muscles of the fora. Just like this one provided the common origin for the superficial flexors of fora, this provides the common origin for the superficial extensors of the fora. Okay, done. So that's the lower part accounted for. Again, lateral border, it's actually projecting upwards, vanishes in this middle section. Again, above, it is limited, it is forming the posterior limit of the deltoid tuberosity. And then spiral groove, this is the spiral groove. It is going up, and finally it's forming the posterior margin of the greater tubercle. That finishes the, I would say, lateral border. Now let's talk about the surface attachments. So as far as the anteromedial surface is concerned, the anteromedial surface is the surface which has the bicipital groove. So we already know what the bicipital groove is and its attachments are. We already know that, so we'll be skipping that. Downwards, in the lower part, both the anteromedial and the anterolateral part of the shaft, in its lower part, in its lower half, I would say, they provide origin to brachialis muscle. The brachialis origin is pretty extensive, as you can see. It spans both anteromedial, anterolateral, and very tiny bit of the posterior part also. It actually peeps into the posterior part a little bit. Right. So that's more or less anteromedial part accounted for. That's also a lot of the anterolateral part accounted for. However, the anterolateral part also presents another interesting thing, which is the deltoid tuberosity. As I've already mentioned, deltoid tuberosity is a V-shaped, tuberosity, roughened ridge-like structure, which is providing insertion to deltoid. So if this is the deltoid tuberosity, the deltoid is coming like this. Deltoid is very extensive a muscle, and finally it is inserted onto here. It is finally getting inserted onto here. Alright. So that's deltoid tuberosity, is V-shaped, and brachialis origin is actually somewhat complementary to the deltoid tuberosity. So deltoid ends like this, brachialis starts like this. So they are in accordance to each other, right? Anyways, so that's deltoid. Deltoid covers the entire upper part of the humerus. But deltoid is also separated from the humeral surface by the subacromial bursa, right? This entire part is actually separated from the deltoid by an extension of the subacromial bursa. We'll study all of this in the shoulder joint. Now, another interesting thing is in the posterior surface, there is the presence of this laterally running spiral groove. It starts from somewhat middle and then it runs like this, as you can see, laterally. This is the spiral groove or the radial groove. What the radial groove actually is, as the name suggests, it lodges the radial nerve. So radial nerve is actually winding around the humerus in the radial groove. However, radial nerve is not the only structure in the radial groove. This radial groove also presents the profunda brachii vessels. So radial nerve along with the profunda brachii vessels, they run along the radial or spiral groove in the posterior surface. Above the radial groove, the part of humerus, the posterior surface of humerus, that actually presents an oblique ridge over in this part, and that is actually providing origin to the lateral head of the triceps brachii. That is the part, posterior surface of the humerus, part of the posterior surface of humerus above the radial or spiral groove. Okay? Whereas below the radial or spiral groove, the posterior surface of humerus, that is actually providing extensive origin to the fleshy medial head of the triceps brachii. So medial head of triceps brachii, very extensively posterior surface below the radial groove, and above the radial groove obliquely we have the lateral head of triceps brachii origin, and we have the spiral groove with the radial nerve and the profunda brachii vessels running in the posterior surface. Alright, and this is the deltoid tuberosity, so that is also accounted for. Now, the lower end of the humerus, let's talk about that, the bony features of that. As we can see, there are two articular processes that we can see in the lower part. The lateral one, this is known as the capitulum, and the medial pulley-shaped one is known as the trochlea. Above, we can also see that there are two fossa present in above these two, the trochlea and the capitulum and the trochlea. These two fossa, the one above the capitulum, this is the radial fossa. Why? Because the capitulum present laterally will actually articulate with the superior surface of the head of the radius, right? So this is the radial fossa, because since its articulation is with the radius, when there will be flexion, then the radius head will get lodged onto this fossa. Hence the name is the radial fossa. Again, the trochlea, above that there is a fossa that is actually known as the coronoid fossa. Why? Because when there will be flexion of the elbow joint, or at the elbow joint, the coronoid process of the ulna, that will actually get lodged into the coronoid fossa above the trochlea. Alright, so what I actually mean by these articulations, let me show you that. Actually, this is the right humerus and I do not have the right radius. I have the left one. But anyways, we don't have anything to do with sides here much. So what we'll do is, we'll show you the articulation. So suppose this is the right radius although this is the left one actually. So what will happen is the articulation will be somewhat like this, and when there will be flexion, let's see, the radius will move like this, and then the anterior part of the head of the radius, that will get lodged into the radial fossa like this. That's why the fossa is known as the radial fossa. Again, this is the ulna, this is the right ulna, this is the right one. So this will articulate somewhat like this. This notch of the ulna, this is known as the trochlear notch. This is the trochlear notch. So that's why the corresponding articular part of the humerus is known as the trochlea. So the articulation will be somewhat like this. So when there will be flexion, this process of the ulna, this inferior process of the ulna, which is the coronoid process of ulna, this will actually fit into the, as you can see, that fossa over there, right? That's why the fossa is known as the coronoid fossa. Whereas posteriorly, during full extension at the elbow joint, posteriorly, this upper process, which is the olecranon process of ulna, this will actually articulate, or rather this will fit into the fossa present posteriorly in the humerus. That's why this fossa is known as the olecranon fossa. Okay, done. So that's all about the fossa and the different articular parts of the humerus. So the trochlea and the capitulum, they are the articular parts of the humerus, but these three fossa, they're not actually the articular parts, because they are not articulating themselves. They merely accommodate when there is flexion or extension, something like that. So they're not articular parts of the lower part of the humerus. A very interesting thing that I would also like to draw your attention towards is this unique thing about the trochlea. See very carefully. As you can see, this is the trochlea, this is the medial flange, and this is the lateral flange. Do you see that the medial flange is extending a little below the level of the lateral flange? So it is extending a little deeper than the lateral flange is. This is the lateral flange. This is the trochlea. Oh, this is the capitulum. This entire thing is the trochlea. This is the lateral flange, this is the medial flange. So medial flange extends about 6 millimeters down or below than the lateral flange. What this will do is, when we will articulate the ulna, instead of the ulna's articulation being like this, if the articulation had been like this, as you can see, the entire structure would have been straight. But since that extra 6 millimeters have to be accommodated, the ulna, instead of being straightly articulated like this, has to deviate a little bit like this. And now see, now the articulation is actually fully active. So see, now the ulna has deviated slightly. It has deviated laterally. See? Do you see? This is the humerus and this is the ulna. It has deviated slightly laterally. So instead of the ulna being like this completely, it has become like this. This actually presents with a characteristic angle in between the long axis of the arm and the long axis of the forearm, when the upper limb is fully extended at the elbow joint and there is supination at the upper limb. In that case, when there is full extension and supination, there is this characteristic angle in between the long axis of the arm and the forearm, which is known as the carrying angle. It is about 163 or 4 degrees, right? It's a little bit more in case of females because of their wider pelvis. Now, why this carrying angle is actually important? It's because this actually presents a space in between the forearm or the upper limb and the lateral side of the thigh and the lateral side of the trunk of the body. What this will do is, this will help us in swinging our arms when we are walking, This will also help us in carrying something and not hit our trunk or hit our thighs while we are at it. So this creates a space between the upper limb and the lateral side of our actual trunk or thigh, which is very important for carrying something, or even walking when we are throwing our arms, right? That's why it's known as carrying angle. Now, speaking of angles, since we are talking about the lower side, let me talk about another angle in the humerus. I had talked about the head, right? Now the head, actually, if I forgot to mention this, the head, that actually makes the direction of the head. If we talk about that, it is directed medially, obviously, a little, as you can see, upwards, but it is actually a little backwards as well. So medially and upwards, these two you shouldn't have any problem in understanding. Backwards, how is it backwardly articulated? Let me show. So as you can see here, I'm trying my best to show you. If you can focus on the lowermost side of the humerus, you'll be able to understand that the lower axis is completely horizontal, whereas the head axis is along the finger in which I'm holding, this index finger, that is slanting like this. So where the long axis, where the transverse axis of the lower part, the lower end of the humerus, that is completely horizontal, we are seeing that the head is somewhat backwardly rotated in correspondence to my index finger like this. So this means that the humerus is actually retroverted, that is, there is an angle of retroversion in between the transverse axis of the lower end of the humerus and the upper end of the humerus, right? Now, as far as the clinical features of the humerus is concerned, we really don't have much to say about this, but we have already talked about this somewhat, that along the surgical neck, the humerus is actually pretty vulnerable to fracture. It is also pretty vulnerable to fracture along the shaft and the supracondylar region as well. However, along the surgical neck, if it is fractured, then that will lead to problems with or damage to the axillary nerve. And axillary nerve supplies the deltoid muscle. So the deltoid will get paralyzed. So there will be loss of overhead abduction, which is pretty damaging. So that's a very important clinical feature of the surgical neck fracture of humerus, right? So that's more or less about the clinical features. It's not got much to, we don't have much to talk about it. And that pretty much sums up, to some extent, the entirety of humerus. I hope this was somewhat fruitful to you, and I hope I wasn't fast enough, or I was fast enough, I wasn't slow, the speed was okay for you. I hope you could understand everything, and thank you very much for sticking with this channel, sticking with this video, and I really do hope to see you later with some other video. Thank you, bye bye, take care.